I've been fortunate enough to be around healthcare for most of my life. I grew up in a family of professionals who are involved in healthcare. I did my training both clinically and professionally in healthcare, and then I moved on to become an administrator in healthcare. And one of the things I learned in those roles is that healthcare and hospitals are really, really busy places where really important work gets done. Every single day we're making life and death decisions. We're changing people's life. We're giving them information that may or may not be what they want to hear. But I also think it's because we get so busy in healthcare, we have the next patient to see, the next meeting to go to, the next to-do list, that we often don't look up and see the forest for the trees. And even though we have some of the best clinicians, some of the best doctors, some of the best nurses, absolutely some of the best facilities for healthcare in the world, we actually have a really sick healthcare system. And as a matter of fact, that system has become somewhat unaffordable, unsustainable, and certainly for many unbearable. As a matter of fact, just today, the Wall Street Journal in their poll identified healthcare as the #1 voting item in the 2020 election. Now that can change, but it actually surpassed the general economy. The only hypothesis for that is potentially more people are spending more of their first dollars in their discretionary income on healthcare than they ever could before, which is affecting, again, the general economy. But we also know healthcare is the #1 cause of bankruptcy in America. But I don't know if you knew, 62% of all bankruptcies in this country are actually caused by the inability to pay healthcare bills. It's not defaulting on your mortgage, your credit cards, your college tuition. It is because of the profession that all of us are involved with. And so when we think about we just save somebody's life on one end, when they leave, they have some burdens on the other end that we're not attending to, we're not actually focused on, and we think our job is actually done and complete. The New England Journal of Medicine this Monday, I'm sure many of you read it, identified through their surveys different focus factors for Americans and their focus on healthcare. 9 out of 10 Americans said that lowering the price on healthcare is extremely important to the economic viability of their homes and of the country. And if we go on down, 84% felt more spending needs to be put towards prevention than intervention. But right now, as a former practitioner and as somebody who actually works pretty heavily with healthcare on a daily basis, I don't really know any codes, and I'm not going to take the annual visit as one of those codes, that actually we get paid for keeping people healthy and well. And so if we think about where we are as a system, there's a lot of cynicism that's beginning to enter the marketplace and the general population around what healthcare actually is. And so a Harvard business professor who I work with, he sits on our board, he said the only people who like healthcare, the healthcare system, are the people who are getting a paycheck from it. And while this might be a little bit cynical, I have to begin to think and ask the question, can healthcare systems actually change themselves and build what's next and actually build healthcare 2.0? Because when I look at this continuum of healthcare innovation to actual disruption, I'm not sure most systems are even on the innovation side yet. And they're building some cool technologies and there's some things going on, but we don't have business model innovation affecting the health system at this point in time. And so where I think that we need to spend more of our energy and our time is not on the latest, greatest gadgets, but actually how do we innovate the business model? How do we change how we deliver, pay for, and manage healthcare in this country? And I don't think it's changing much because I can still drive down the street and I can see these signs almost anywhere in America. And so we're encouraging people, whether directly or indirectly, to use one of the highest cost care facilities you possibly could to go receive your health care. We're not recommending they go to the right spot, the right location, or the right time, but you only have a 4-minute wait, why don't you come on in? And then we begin to ask, why is the system set up this way? And we have to go back to the wonderful quote that every system is designed to get exactly what it's getting. We set it up this way. It has continued to be set up this way. And so let's ask ourselves the question, is the setup delivering the results that we want? So for the people in this room, many of us who have benefited, including myself, from being in healthcare, both financially and professionally, it seems like it's been a fairly good system. I was responsible for mergers and acquisitions, hospitals coming in, physician practices coming in, grabbing market share. But when we look at the bigger picture of what we're actually doing, we have to really stop and pause and ask, is this sustainable for everyone? Is it sustainable the way that we're doing it going forward? So some of the results that we're getting, and certainly looking at life expectancy is kind of a blunt instrument, But you would think or hope at some level that a country that spends $3.7 trillion, 18% of the gross domestic product on healthcare, would have higher life expectancies than countries who actually don't spend those dollars. But unfortunately, that's not the case. So let's take a look at some of the other results. Our total expenditure per capita is about double other OECD countries are in healthcare, almost twice as much. So are we getting the results for that? Well, unfortunately, we're not. If we take a look at amenable mortality or mortality that could have been avoided by delivering the right care at the right time in the right situation, America ranks last out of the other OECD countries. If we take a look at disability, disease, and the rate that we have disease in this country, we have the most reported disease than any other of the OECD countries, which talks to bigger societal issues that we need to face when we're looking at healthcare and what does it actually mean to be in the business. And then actually areas where we could avoid disease or prevent admissions into hospital, we rank last in almost all the categories in keeping people out of hospitals, because in many ways, we're encouraged to get people into hospitals. And unfortunately, if we look at deaths per 100,000, infant mortality, cancer, diabetes, respiratory disease, and coronary heart disease, with the exception of cancer, we don't even meet the average of the other OECD countries on the list. And so we're beginning to ask, what have we really set ourselves up for? And I think what we've set ourselves up for is a very volume-based, consumption-driven health system. And I think this stat's pretty revealing that 5% of the world's population lives in the United States, but 50% of the pills that are taken in the world have come from the US, and 80% of all painkillers. If this doesn't scream that we're in a prescription-driven system and we're trying to give people pills to change their health and wellness, I'm not sure what does. And so as we look at where things need to go, we need to begin to ask, do we even know how to consume healthcare in this country? And my answer would be, I don't think we do. And part of the reason is most of the fair market principles and open market principles that drive other aspects of the economy just are not present in healthcare. And so we're not going to go through all of those, but a few I just want to touch on is we don't have clear and fair pricing, competition, we could talk about that in a minute, and then value and quality evaluation. What's funny is that I can go on to Best Buy, and if I want to buy a refrigerator, which its job is to really just do one thing, keep my food cold. That's really all my refrigerator does. But there's an incredible amount of work that actually goes into building a refrigerator, from sensors and water and plugs and electricity and metallurgy and all these other things. And you actually have to get this mostly shipped from China to the US. But even doing that, I know the cost of that, what it's going to be. And it honors all three areas. I have my competition and a price match guarantee. I have my clear and understandable cost. And I have my quality evaluation right there. And so I can understand what I'm actually taking a look at. When we go into healthcare and we begin to examine how do we evaluate pricing, we get confused very, very quickly. Whether we're receiving a bill for the anesthesiologist as well as the orthopedic surgeon as well as the hospital bill and so on and so forth, we don't know how to consume healthcare in this country. And if we want to really create a consumer-oriented healthcare system, we're going to have to make some changes in how we do some basic things that other industries have already done. And let me give you some examples. This is the average price of a full knee replacement in different locations in the United States. And you can see if we go to Louisville or we go to New Jersey, it can range from $22,000 to $50,000 for the exact same procedure. That's different than the price of that refrigerator I was just looking at. It's not going to be double plus. If I go and look to get a lumbar MRI, and what's interesting about this one is I've lived actually in Farmington Hills, and I currently live in Chicago. And I can tell you they're very similar environments, but the prices of $400 for that MRI versus $1,100 don't make sense. And if you begin to think, well, those are really different geographies, and who knows if they're using similar equipment or what's exactly going on, we can even take a look within an actual city itself and find that in Philadelphia alone, hospital-based MRIs can range in value by 6x from one location to the next. So there's a lot of questions that need to be answered about what it actually means to be in healthcare as we go forward and what detriment it's bringing to the economy and how we're going to actually change it as healthcare leaders and providers as we go forward. The second principle I want to talk about is competition. Between 2013 and 2017, about 20% of all health systems merged with a larger system. And most of the time we think that's a good thing. I'll talk to you why I don't think it actually is for healthcare. And we also have in some states a certificate of need. How many of you are in certificate of need states, just by a show of hand? There's no other place that allows a certificate of need except healthcare. And for those of you who aren't in it, it essentially says you can't open up certain facilities or buy certain equipment without showing an actual need in that marketplace for that type of equipment or service to be provided. Simple things like an MRI, for example. If I wanted to buy an MRI machine in Michigan, I couldn't do that for myself. In Illinois, I actually can. But the problem that we continue to find is that when health systems merge, they don't get the economies of scale and the benefits that other systems do. We actually get diseconomies of scale. And we begin to see that prices go up by as much as 50% on some service lines, but an overall increase by about 12%. And part of the issue with that is that we're beginning to create monopolies in different markets where we can begin to manipulate pricing, our relationships with the payers, so on and so forth. And so what we actually begin to see happening in other industries doesn't seem to be working in healthcare. And more evidence of this is this, that if you actually take a look at environments in this country, communities in this country, where services are delivered that are the exact same as in other markets, those markets that have more of a monopoly-based or less competitive market infrastructure for healthcare are significantly higher priced than those who have competition. And yet we do not encourage competition in the health marketplace. The other thing that we don't know how to do, and I've been involved with quality for almost all of my career, is we don't even know how to evaluate quality. I'm not sure that I've heard a really good definition of quality evaluation in any meeting I've been in. I'm not sure I've heard it consistent through other health systems. I was recently in a quality discussion with a couple of health systems, and the cardiologist in the meeting said, I evaluate quality when I know that the person survived. Okay, I'm glad that works, but I'm not sure that's the exact best way we should evaluate quality. It also leads to unnecessary care and a huge amount of spend that we don't need to do. But there's another problem, and that problem is we continue to grow health systems like they have an uncontrollable ability to generate cash and take in money. And as a matter of fact, from 1970 to 2009, the US population increased by about 150%. And doctors increased by about the same amount as the US population during that time period. But today, and this is actually not even current, it's even higher, we've increased healthcare administrators by 4,000%. Okay? We now have a chief of everything. We have a chief transformation officer, a chief digital officer, a chief strategy officer. We have a chief of everything. And that's not necessarily a bad thing, but those chiefs begin to add vice presidents under them, who had directors under them, who had individual contributors under them. And before you know it, we have 36,000 employees that are only people billing are 1,000 physicians. And so when we begin to take a look at the infrastructure and the costs that we're actually dealing with, we've got to ask ourselves some really difficult questions that we'll attend to in just a moment. But there is great news. I promise, there is great news. And the great news is that there's a ton of opportunity for improvement. And I think we can make that improvement, but it's going to take some very difficult questions, and it's going to have some very difficult and sometimes undesirable answers. But I do believe disruption is going to come to healthcare. I'm just not certain it's going to come from within inside the healthcare system. Just by a show of hands, how many of you do you think that the disruption is going to come from within the health system? 0. How many of you think it's going to come from another place, unexpected place? Most of you. So I agree with you. And I've been fortunate to work with some of the companies out there that I think are going to be doing this disruption. And I was sharing at my table earlier, they have no concern for what we have in place. They don't care about our existing infrastructure. They don't care about our legacy cost. They don't care about our buildings that we put up. They don't have any concern for that. Their concern is to change the story and the narrative around what healthcare means in this country, how it's paid for, how it's received, how it's delivered. And so I think there are 5 major disruptors, and we don't have time today to go through all 5 of those. But I want to talk about a few, and one of them that I'm not going to get into, but I want to bring to your attention, is employers. I think what JP Morgan, Chase, and Amazon have just done with creating Haven is just the tip of the iceberg. And some meetings that I've been in where some of those people from those companies are present is I think they do have a formula for being able to come in and actually begin to change how we think about healthcare, whether that's direct contracting and pushing the payers out, whether it's about expertise areas, or really whether it's about changing what we're even thinking about in the business and the industries of healthcare. So how do we move to healthcare 2.0? How do we build what's next? Where do we start? I think what you need to do is you need to look at where's the money going? Where are we actually spending our money in healthcare? And what you'll find is that if you fix chronic disease, you actually can fix the healthcare spend. And this becomes something that's really, really important, but we don't spend that much time on. But when you begin to actually look at the data and begin to take the layers of the onion back, you begin to see that 75 to 90% of that $3.7 trillion is spent on chronic disease, okay? 80% of those chronic diseases are attributed to lifestyle choices. 4 main choices: what people eat, inactivity, smoking, drinking, and the 5th one is unprotected sex. And so those are behavioral components. Those are changeable things. Those aren't genetics. Those are things that we could potentially change. But unfortunately, we think it's more sexy to put up the new $150 million tower with somebody's name on it than we do about redistributing healthcare and making sure people have access to good food and access to transportation and these other things that actually drive outcomes a lot more than the latest Da Vinci robot. But we don't pay attention to those things in this country. And if we don't start realizing simple things like food is medicine will make a bigger difference than that prescription does, we're going to miss the boat on healthcare, and someone's going to say, we gave you guys a chance to change healthcare, now the adults are coming in to fix it for you. Because it's not a sustainable marketplace, it's not a sustainable industry for the rest of the economy as we go forward. So why do I think this is important? Because I know that prevention is better than intervention, and as Benjamin Franklin said, an ounce of prevention is worth a pound of cure. We don't spend time here. And we need to begin to start looking at this differently. And I don't think we spend time because we just don't get paid for it. But there is tremendous evidence that behavioral change is sustainable. And some recent work that was done and Milliken reported on is 58% in a type 2 diabetes program sustained the benefits of that program 3 years after the program ended. Okay, we also know throughout some work of Howard Brown on HIV medication in Chicago that about 40% of people were being adherent who had HIV to their medications. After their program, 88% remained adherent 3 years later as well. We know behavioral change and modification is difficult, but we're not funding it appropriately. And instead, what health systems are becoming is catchment areas of all these lifestyle activities way downstream versus preventing it upstream, where we could do a lot better job in a lot different way. And so I think we all have to remember when we're in healthcare, health actually happens outside of the healthcare system. And we forget that. So all of us are given in the standard year the 525,600 minutes. The average US citizen spends 12 minutes with a clinician. 12 minutes. That leaves, and I hope I did the math right, 524,588 minutes where health happens outside of the healthcare system. And so as we begin to look at this, it probably is no surprise to you that the calculations are that about 10% of your overall health is actually attributable to the healthcare that you receive. 10% for a $3.7 trillion spend, to me, is an outrageous number, absolutely outrageous. But the other 90% is spent on genetics, and the behavior and your environment account for the majority of this. And what this is doing is this is actually opening up a lot of white space for disruptors to come into the space we've traditionally owned. And the space that they're going to attack is not our high tertiary and quaternary areas. It's going to be the place where most healthcare takes place for most Americans, which is the primary care visit. And so if we look at the number of ambulatory visits last year, there were 1.2 billion ambulatory visits. About half of those were the primary care. That's actually down 18% over the last 4 years, and we're continuing to see a drop again this year. We wouldn't expect that, given that the population's aging. But one of the reasons that we're beginning to see this is there's alternatives to the way they're receiving care in the past that are beginning to be acknowledged and utilized. One of those alternatives made an announcement yesterday. And anybody see that CVS announced by 2021 they'll have an additional 1,500 health hubs in their store? And those health hubs will have clinical care, as well as lifestyle management, as well as things like yoga and meditation and other things that they can actually focus on managing someone's overall health and well-being. I think that the CEO of CVS actually said it fairly well. The traditional healthcare system lacks the key elements of convenience and coordination that help to engage consumers in their health. Think about your experience or your family's experience with healthcare. How difficult is it to get in? How difficult is it to understand what you should do after the visit? When you need to get a question answered, how long do you have to wait to have that question answered? We're not set up to be a consumer-facing industry. We've been set up to be something very different. And we continue to pretend that we can just flip the switch and repurpose John from IT as our consumer analytics guy now. And that's not the way that this works. And it's not the way we can take healthcare seriously. In my new role, I've had a lot of pleasure to work with some of the tech giants. 2 weeks ago, I was in San Francisco, and I had dinner with one of the leaders of one of these companies' healthcare divisions. And he asked me a question that kind of caught me. I led innovation at my health system as well. He said, how much did you guys spend on health innovation last year? In R&D and health innovation? And the answer is not that much, right? Maybe $5 million if I'm being generous. They're planning on spending $5.9 billion over the next 2 years on new health innovation and technology. How can we keep up with that? How are we going to be able to adopt that? And how and why are we not working more closely with health systems to actually bring these solutions into the market? But it's not just the large players, there's a ton of healthcare startups. So I invest in companies now, and we look at startups all the time. These are just a list of some of the companies that have come across our desk with the opportunity to invest in. And this list is about 400 stronger than what I currently have on this sheet here. But what we're seeing from these health disruptors, these new entrants, is they're thinking about the game differently. And in our current world, we're extremely episodic, intermittent, and reactive. They're starting to create a world where they said, hey, you know what if we did the genetic testing at birth, and we understood at birth that you might be predisposed to some certain conditions that we could work with you on throughout your entire life, whether that was keeping arthritis away or managing potential heart disease or cholesterol levels. What if we would actually work with you and then we actually hook you up with the right technology and consults and the ability to actually engage differently with healthcare than we ever have? For us, what do? We wait for something to go wrong and then we intervene and we think we've done our job. But we're missing opportunities left and right to actually build loyalty with the consumer, to actually build other opportunities to keep the consumer healthy and well. And there is a financial model here that works, not only for the consumer and for the health system, but for the country. And so if we do that, we need to begin to realize currently our business is really, people have to come to us because they have to. They just had a transplant, they have to come in and see us. They have to have a bypass surgery. It's needed. They broke their leg, they have to get it in a cast. But if we truly want to begin to play where the healthcare 2.0 groups and disruptors are going, we actually have to start building products and services that they need and want and are desired. The problem is, I don't think most health systems even know what's possible, and they're not embracing or incentivized to keep people healthy or to keep people in touch with what's next. But the disruptors are actually asking a totally different set of questions. They're asking questions like, what if we could predict disease or a health crisis before it happened? And through big data and artificial intelligence and monitoring, they can. They're asking, what if we could alter genes to eradicate disease? I began my PhD in genomics. This is something that's fascinated me for a long time. It's something that actually is possible now, and it's happening in China, and it's actually happening in London. We could eliminate and tailor medications to an N of 1, and we could deliver care at the precise moment that it was most beneficial. These are the questions that are being asked by the disruptors, not by the health systems. And I think we need to begin to flip that and realize that science and technology are outpacing payment and practice. So where we can go and where we are just not aligned right now. And so I'll talk quickly about some things that we're seeing in the marketplace. And all of you have heard about all these at some level. But one of the things we're looking very heavily at in our portfolio is actually liquid biopsies. And I recently had an opportunity to review a company where I'm going to explain it absolutely horribly, and they would say I totally muffed it, but I'll give you the general idea. They insert a nanotechnology into the arterial wall, and what sits there, it's powered by the circulatory system, just as a river powers a dam, so they don't have to put in an energy source, and it actually monitors circulating tumor DNA in the blood. If it's identified once a day or once a week or however if they want, they just have to put a device up to where the chip is inserted, and it'll actually give a read if there was anything that came through or not. Now you talk about early detection, and you talk about the ability to prevent cancer and other diseases. This is the type of thing that we're not set up to do, we're not ready to do and we're not thinking about doing as healthcare systems, but we need to begin to get there. We begin to talk about pharmacogenomics. The top 10 selling and revenue-producing drugs in the country have very little benefit on most individuals who take them. Yet, we talk about the rising cost of pharmaceuticals. We talk about the increased pressure that the pharmaceutical industry is putting on people's monthly income, and yet most of the meds that we take don't even work. And so we need to begin to ask, why are we not reimbursing? Why are we not using pharmacogenomics in this new world where this technology and capabilities available? CRISPR, how many of you have heard of CRISPR, just by a show of hands? So a number of you. This is absolutely amazing technology. I don't know if any of you read yesterday in the Journal of Genomics about what they're doing in China, and they were able to eradicate very, very deadly lung cancer. And so this person was basically on their last leg. They were able to go in and use CRISPR technology, and this person is now alive 2 years later when they were supposed to maybe live 30 to 40 days as long. So we're beginning to see the eradication of disease, but we won't get here, I don't think, until we start realizing we have to shift what healthcare means. And so we've been in a very patient-centered, focused world. We're moving to a consumer world, although I would question, is this actually real or does it just sound good? And we really need to recognize that scientific prevention needs to lead where we go next in Healthcare 2.0. But in order to get there, we have to ask ourselves some difficult questions and make some really difficult changes. And these are not popular. These do not get me awards with anybody in the healthcare administrative pool. But are we too big of a burden on the economy? We have to ask ourselves that. Are we taking too much of the GDP? If 20 cents of every dollar is going to healthcare, it's not going to education, military, roads, so on and so forth. Should we be not-for-profit? I think this is a question that's going to get a lot of debate coming up. And most health systems say, well, we deliver a lot of care and we do it for free. The benefit, actually, the most recent studies, about 40% of health systems actually don't deliver the benefits back to the community that are equal to the tax benefit that they received. And I bet you the number is even higher because the number they're using to evaluate that is off the charge master, not off the actual rates that they would actually be charging a Medicare or a commercial payer going forward. We have to ask, should not-for-profits have billions on their balance sheets? Should the executive teams be paid millions of dollars to be in healthcare? These are questions that we have to begin to struggle with, and other countries are well ahead of us in struggling with those questions, and we're not there in America. But if we don't do it, we're going to find ourselves in a very difficult position as healthcare providers and administrators. So as I said earlier, what I think we really need is business model innovation and transformation. I'm going to talk about these very briefly. The first thing I think health systems need to do is they need to begin to collaborate with other health systems. We stink at that. Everybody does their own thing. That means we have, probably in this room, if we have 15 health systems, we probably have 15 different groups who are building their own telemedicine platform. You know what you're building? A sub-optimized solution that you're never going to be able to commercialize and bring to the market anyway. So why not find one solution that we can utilize and actually scale throughout the country, set the standards for what that means, and actually decrease the cost and the expenditures that we have in our telemedicine departments. And we could look at these from all sorts of areas, from surgical supply spend to other things that we want to do around precision medicine. But I think the key here is that there is not going to be enough liquidity in any system, and there's not going to be enough competencies in any system to actually build what we need to do in healthcare going forward. And I think coalitions are one way to do that. In January, an article came out in Modern Healthcare that said 2019 will be the year of coalitions in healthcare. The health systems will begin to come together. I haven't seen it yet. I hope it happens. We're trying to make it happen. But I think we're better together than we are trying to build everything on our own. It reminds me very similar to the educational system. Why do I have to have a great Spanish teacher in every classroom? Why can't I have an assistant? And we beam in the best person from whatever university there is to teach Spanish who has the best style and approach to do that. We're not leveraging our capabilities in any way. Instead, we continue to ask cost and burden. We've seen Civica do this. I led the Civica process for us at our health system in Michigan. And what I love about Civica is health systems coming together to make sure we have mission-critical drugs available at a meaningful and fair price in the marketplace. We can do this with everything. Health systems can come together and do this with everything. We all don't need our own. And until we start realizing that, there's no way of driving down our infrastructure cost. We're going to be stuck. We need payment reform in a big way. The first thing I think we need to start with is standardized and transparent pricing. Nobody knows what anything costs. And nobody knows the real cost because when they go in, That's the cost for one part of the procedure, but it's not for the other parts of the procedure. We need that. We need transparency on everything. So I, as a consumer, can go, what are the infection rates? What are the mortality rates? What's the sepsis rate? I need to know everything about the product I'm about to purchase if you want me to become a true consumer of healthcare and what's going forward. And then we need to look at hybrid payment methods. Yes, fee-for-service can stay, but it can't be the only method, and it can't be the only one we rely upon the most. But fee-for-service for your dermatology appointment's great. Bundles are great for your ortho procedures. You know what? Let's go capitation for chronic disease. There are ways that we can blend and have hybrids of payment methodologies that don't put this volume number in front of us that continue to make us have 5% of the world's population and 80% of its prescriptions. Just doesn't make sense. So as I look at where we're going forward in healthcare and where we need to be, is we need to really move away from this idea that the center of the universe is the hospital, and we have silos, and we have illness, and we have patients. So we need to become borderless. We need to have many more partnerships. We need to work on wellness, realize we can get to the N of one, and healthcare needs to be on demand, like everything else is and everything else we expect in our lives. So I think changing in healthcare means going from episodic and reactive care and bricks and mortar much more to a world where it's always on, it's predictive, it's preventative, it's personalized, and we can begin to make a difference in ways that we never have. So what I ask is, I hope that tonight, and I'm telling me to get off this, I'll be right there. I hope tonight what I've done is I've at least planted some seeds with you that will grow not into that tree, but that forest, where together, all of us can actually change healthcare and what it means in this country. So, thank you.